Hello and welcome to another Intensive Care Hotline and Intensive Care at Home live stream. I'm here to answer your questions and I want to welcome you. Also want to welcome you if you're watching this on replay. But it's always better to be here live so that I can answer your questions in real time. Okay, so today's live stream, before we get into the questions, just a little bit about myself, what makes me qualified to run these live streams and answer your questions if you have a loved one in intensive care. So my name is Patrik Hutzel. I'm a critical care nurse by background. I have been working in critical care / intensive care for over 20 years. I have worked as a nurse unit manager in critical care, intensive care for over 5 years. I've been consulting and advocating for families in intensive care over the last 10 years here at intensivecarehotline.com. I'm also the founder and managing director of intensivecareathome.com. With Intensive Care at Home, we are sending intensive care nurses and critical care nurses into the home for predominantly long-term ventilated adults and children with tracheostomies, but also otherwise medically complex clients, such as for adults and children that have a tracheostomy but are not ventilated, for adults and children that are ventilated but don't have a tracheostomy ventilated with BiPAP, CPAP, also home TPN, home IV potassium infusion, home IV magnesium infusions, port catheter management, PICC line management, central line management, Hickman's line management. That's all part of our scope of what we do. Now, with Intensive Care at Home, we are currently operating all around Australia in all major capital cities, but also rural and regional. But even if you are in the US or in the UK, we can help you privately. So please reach out to us if you need help one way or another. Now, before I get into today's questions, let me just start with a great success story from the last few days. And this is how it relates to our US clients in particular. So we were consulting a client in Connecticut who had her mum in her 70s in ICU after an aspiration pneumonia. She was ventilated for couple of weeks, it was very much touch and go. She was on 80% FiO2, PEEP of 10, sometimes up to 12. Controlled ventilation mode, was heavily sedated with propofol, Versed, /midazolam, and fentanyl, and there was no way that it was looking she would improve, but she did over time. And with our, consulting and hand-holding really of the family, but also talking to the ICU directly, she managed to get extubated eventually, avoided the trach, right, which was really the goal. She went from being extubated onto the BiPAP, alternating between BiPAP and high-flow nasal cannula, and then eventually went home. But here's the good news. She went home with us setting up home care privately. We have now nurses in the US as well that can help with setting up home care privately. So, if you're in the US or in the UK and you're wondering, how can I make this happen for my loved one going home? Please contact us, whether you're in Australia, whether you're in the US, whether you're in the UK or in any other country. We can help you one way or another. Now, this lady is now at home with private nursing because the family did no longer want her in this particular hospital where they simply didn't feel safe. So please reach out to us. We can help you with the transition one way or another. We can help you with the consulting in hospital, in ICU, walking you through it step by step, making sure you know exactly what's happening, making sure you know what the numbers mean, making sure, you can ask the right questions, or we can ask the right questions on your behalf. We can look at medical records, which is something we've done in that situation. We've looked at medical records all the time to guide the family, to help the family understand, how to move towards extubation, how to avoid the trach. And then eventually she got extubated, and within a few days, she went home with private nursing. So, that was a real success story. And we have Tara in the US, who is our clinical liaison nurse. I've actually done an interview with Tara. I'll probably link towards the podcast with her so that who's working for us when it comes to home care in the US in particular. Tara used to work for us here in Australia with intensive care at home, and now she's helping us in the US. She's a US citizen to get it off the ground in the US. So step by step. So we've had our first success story. Now, coming to today's questions. Now, if you have a question and you're live on the show here, please type your question into the chat pad and I will answer it here. Or if you want to come on live on the stream here, you can do that by clicking on the link here. I've just posted the link here, the StreamYard link. So if you want to come on live on the show here and you want to ask me a question, please use that link and ask me questions here, or just type them into the chat pad. You don't need to go on camera. If you don't want to go on camera, you can just, click on the link, join me here. You don't need to go on camera. You can just talk to me. Either way, I will answer your questions. I will get to them in a minute. Just need to look at the emails that have come in. Just give me 1 second. There is the first email that I'm going to answer today. The first question today from Melissimo, who says, "Hi Patrick, my biggest frustration is that my mum is in neurointensive care with a traumatic brain injury, but also suspected glioblastoma tumor. The ICU is withholding imaging, surgical removal, partial resection, and is delaying pathology results. What should I be doing?" Wow, that seems to be like a big challenge, Massimo. So she's in neuro ICU. So why does she have a TBI / suspected GBM tumor? Did she have a fall and therefore has a TBI? So, and it sounds to me like the ICU is not transparent with you, which is a big challenge. If the ICU isn't transparent with you, assuming you are the power of attorney, you need to get access to the medical records and see what's in there. You know, you need to see what's in there, what diagnosis is in there, what's documented. Does she have a TBI? Does she have a GBM, a glioblastoma tumor? Why are they withholding imaging? Why are they withholding surgical removal and partial resection? Now, I think I have an idea why they are potentially withholding resection or surgical removal. Glioblastoma are very aggressive brain tumors, and most neurosurgeons would deem them as quote unquote inoperable. Now, some of you might have heard of Dr. Charlie Teo, who's a famous, and some people might say infamous, neurosurgeon in Sydney, Australia. He in the past would have operated on those tumors, but they deregistered him as a medical professional, which I personally think is a big shame. I do believe that Charlie Teo has done way more good than bad. I have worked with Charlie Teo in one of the ICUs that I worked at. I've worked with him personally, and I believe he has done way more good than bad. Is he perfect? No, no one's perfect, but he has done way more good than bad from my personal experience working with him. You know, it's a while ago. Would have been sort of 2005 to 2008, so nearly 15 years ago. But, you know, I think he's done great work. Coming back to your question, Melissimo, so you might need to find a neurosurgeon that is interested and able to operate on your mom. If they're delaying the pathology results, once again, put the pressure on, get access to the medical records, and make a complaint to hospital executive why they are delaying pathology results. You know, get the wheels in motion. That's really important that you get the wheels in motion here. And once again, once you have access to the medical records, we can help you. But even if you don't have access to the medical records, we can help you get access to the medical records, because we've helped so many clients in similar situations getting access to the medical records and then also interpreting them, of course. You know, we've also helped many clients with writing letters and emails to hospital executive so that their complaints are heard. And I can assure you, a hospital executive or hospital executives cannot ignore the complaint. They can't. Right. So whatever you're finding is going on in ICU, take that out of ICU and complain on a different level. They have no idea. Hospital executive has no idea what's happening in ICU on a day-by-day basis. Therefore, you need to take it to a different level, which is hospital executive. Next question and comment that I had from one of my YouTube videos is from Helene, who's a regular watcher here, regular viewer, and also regular person that's commenting here, who says, my mom was an iatrogenics victim to covert euthanasia, violent medical exploitation, gaslighted, abused, deviated from standard of care, medically tortured, unnecessary restraint tortured, and imminent death murdered. Now, Helene, I know, you know, you have been on this show and you have shared some of your mom's journey, which is your journey as well, of course. You know, it sounds to me like you've been through the worst, and thank you so much for sharing your story. You know, you have been live on this show as well, and it's really good that you're doing that, and I want to thank you for, you know, sharing your story with our viewers here. Okay, next question is from the next question is from Nicole, who says, hi Patrik, the doctors are recommending not using a tracheostomy due to my mom's previous strokes. It took 13 minutes back to life. during CPR after cardiac arrest. She's 90 years of age. She has been on the ventilator 7 days. So basically what you are saying is they're not recommending a trach because of her age and because of previous strokes. But it's not that they're saying they're not recommending a trach because she can't have a trach or a trach is not the right thing to do. They're basically saying it wouldn't be, quote unquote, in the best interest of your mum to have a trach. Well, Nicole, here's the thing. You know what's best for your mum and you know what your mum wants. How does she view her current situation? Does she want to live? My biggest advice here is make decisions today that you don't regret in 12 months' time. If you regret if you might regret what you decide today in 12 months' time, you're not on the right track, right? So if you buy into this frame of mind, then then she may not have a tracheostomy and then she may pass away, right? If you don't buy into this frame of mind, then she may have a tracheostomy and she may have a second chance and she may have a fair chance as well. So keep that in mind. Keep that in mind. Now, also with services like intensive care at home, can she have palliative care at home, whether that's with or without a tracheostomy, right? Also, what are your mum's ventilator settings at the moment? Is it likely that she can get off the ventilator? Is she waking up? What's her Glasgow coma scale? What are the CT scans of the brain and the MRI scan of the brain showing? What are the EEGs showing, if any? Is she still on any sedation? Is she having seizures? If yes, is she on anti-seizure medication, potentially adding on to sedation? Right? Is she getting mobilized? Is she getting good nursing care? Is she surrounded by a positive team? It doesn't sound to me like she is. Right? If she has been on the ventilator for 7 days, she still has time to come off the ventilator. You are saying it took them 13 minutes to get your mum back to life after CPR. Okay, was she starved for oxygen during those 13 minutes, or could they maintain good cardiac compressions with oxygen, with good oxygen output to all the organs, including the brain? Some patients don't wake up after an induced coma without brain damage. So keep that in mind as well, that sometimes patients just need time, but you need to get the facts here. And the facts that you need are, okay, what does a neurologist say? What does the CT scan of the brain show? What does the MRI scan of the brain show? Is she sedated? Right. If so, what is she sedated with? If she's not sedated, why is she not waking up? Right? Those are the questions here that you need to ask. But once again, what are her ventilator settings like? Maybe she can come off the ventilator, but she needs a trach because she's already breathing spontaneously. But she needs a trach because she can't swallow. She can't cough. You haven't mentioned any of that. Is she coughing? Is she gagging? Can she protect her airway? Right? Is there any sign of life at all? What's her Glasgow coma scale like, i.e. neurological response? Once again, this is a typical question where I go like, yep, you don't know what you don't know, and you don't know what questions to ask, and you don't know what to look for. Right? It's up to you what you want to do next. It's up to you, assuming your mum can't make her own decisions right now. It's up to you if you want a trach. If you don't want a trach, it is entirely up to you. Right? Let's get on to the next question. Again, from Helene, who says, while at WA while at WSAMCS, my late mum self-extubated herself because the respiratory technician deliberately, negligently did not put a tooth guard in her mouth. She had to be reintubated. Mum was forced on a ventilator and tracheostomy due to iatrogenic malfeasance, manipulated induced personal injuries, pneumonia. Right. Again, we don't have the facts here, but I know you have the facts by looking at the medical records, Helene. And once again, thank you for sharing all of this. Next question from Gita, who says, "Hi Patrick, I love your website and YouTube channel. We live in the United States. My dad had large ischemic stroke at 54 years of age 4 years ago. It left him with a right side paralysis and aphasia. His speech wasn't affected. He was stable and regained his memory and was walking with a small cane and some assistance. His vision was affected and he had balance issues, but he was okay, engaging with daily life, albeit with disabilities. A month ago, at age of 58, he went into focal seizures, and the ER checked and sent him home after 2 days saying no seizure or stroke. They didn't do an MRI or seizure test, they just did a CT scan. After he came home, he was having severe balance issues. Then 2 weeks ago, he had a huge intracranial hemorrhage and got a craniotomy done. We were told it was a large left cerebellum bleed. He's currently in ICU, day 17, on pressure-assisted ventilation with central fever and on seizure medications as well. His body is stable. He's off sedation now for a week." Now the email continues. And I'll just quickly need 1 second before I go back on camera. And then the email continues. "I read your blog and the question for this situation is similar to Shanti's 91-year-old father. On day 2 after surgery, he waved bye to us when we spoke to him in our native language. He made a small left hand movement and left foot shake. The nurses feel it's random and he is not responding to them when they ask in English. The central fevers came and he was shivering and shaking and was put on seizure medications, but they found no seizures. A few days later, they called speech therapists because he was answering few questions right, like with his eyes, like, is Obama the current president? The next day or so, they sent palliative care to talk to us, which we refused. They want to send him to LTAC after tracheostomy and PEG on Monday. My dad looks around when we talk to him and we feel he's there mentally in minimally conscious state because he tries to move his left thumb to say bye when we ask him a few times. But the nurses feel we are thinking too much. There is no speech therapy anymore. No mobilization as well. We asked if he has any bed sores. The nurses say none. He still has fevers on and off. He was doing good on spontaneous breathing trials 3 hours, and then suddenly, after we agreed for a trach and a PEG, the nurses started saying he's failing breathing tests and that's why he will get trach and PEG. Not sure if it's on purpose for insurance reasons or not. We are confused what's going on. The nurses are feeling like we are bothering them when we ask about his progress. I asked them to check with neurodoctor on putting him on neurostimulants to get him conscious. Let me know how to proceed. We feel it's too early to give up on him. We are on Medicare insurance, so it covers 100% for 60 days of ICU. We don't want to go to LTAC if we can avoid it. We are interested in DOC programs and neuro rehab once he's on room oxygen. I'm not sure what you mean with DOC programs, but I'll have a look at that in a minute. Let's just break your email down step by step. So your dad had a large ischemic stroke. He was living at home for 4 years. His vision was affected and he had balance issues, but he was okay with engaging with family, day-to-day life with disability. He went into focal seizures and a month ago, and then sent him home after 2 days saying no seizures and stroke. They did not do MRI or seizure tests. They just did a CT scan. After he came home, he was having severe balance issues. 2 weeks ago, he had a huge intracranial hemorrhage and got craniotomy done. We were told it was a large left cerebellum bleed. He's currently in ICU day 17 on pressure-assisted ventilation with central fever and seizure meds as well. His body is stable. He's off sedation for a week. Well, okay, so first off, why did he have bleed? Did he have a bleed because, he was on anticoagulation that was unmonitored? Did he have a bleed because he had high blood pressure? Did he have an aneurysm? Right? Well, if you talk to him in your native language and you think he's there, he's responding, then you should be paying attention to that. And I know you do pay attention to that. Right? Don't let other people discourage you from what you know is your intuition and what you know is your dad speaking to you. So don't let other people discourage you about that. Right? And if the nurses feel it's random, so be it. You can make your own judgment. You don't need the nurse's approval. You know your dad. So the central fevers came and he was shivering and shaking, and he was put on anti-seizure medications, but they found no seizures. So why did he have central fevers? Well, he does have an intracranial bleed, so it might impact the bleed, might put pressure on the brain, and that might impact on his ability to temperature regulate his body, right? Or he simply has an infection, right? So if he has an infection, where's the source of infection? Have they sent a sputum sample? Have they sent a blood sample? Have they sent a urine sample to see where the infection might originate from? Right? So then you're also saying, now, have they put him on anti-seizure medications? They've done that. Is he still on sedatives? Right? Because you're saying he's in a controlled ventilation mode. What would happen if they switched off sedation? Will he wake up more? Is there a possibility he can wean off the ventilator? Right? Those are questions you need to ask. Because, he's responding somewhat. Are they opting for a trach and for a PEG because he's not off sedation? So here's the ideal scenario. Get him off sedation, mobilize him, get him to breathe up. And if you can do all of that, can he move towards extubation? If he can't move towards extubation because he might not be able to swallow, right? He might not be able to cough or gag. He might still be able to come off the ventilator, but needs a trach, but without a ventilator, right? I don't think that anyone has shown you or explained to you what the different scenarios might be like. Right? So, and of course they want to send him to LTAC after trach and PEG. They don't want to take responsibility for getting your dad extubated, because that can take some time, it takes some work. The easier option for them is for you to give consent to trach and PEG and then send him to LTAC. That is the easier option for them. Right? So once again, the much better option here is to get him extubated, get him off sedation, get him extubated, and that would be the much better option. Because if he then goes on to neurology rehab, it'll be much easier to focus on just the neurological rehabilitation rather than focusing on the trach and the PEG and the ventilator, right? You want to focus on the neurology rehab, and you want to get rid of that ventilator and breathing tube now if you can. My first question here, if I was you, would be if he's sedated or not, if he's on any opiates or not. Because if he is, no surprise, he's not waking up properly, right? And if the nurses are telling you you are thinking too much, don't worry about it. Go with your gut and go with what you know is right. But even more important, you need to get access to the medical records. Okay, you need to get access to the medical records, and you need to see what's really going on. What are they not telling you? ICU teams are notorious in not even telling you half of the story. Right? So get access to the medical records. We can look at them and help you find out what is really going on. Are you even asking the right questions, depending on what's going on? Okay, so you're saying my dad looks around. My dad looks around when we talk to him, and we feel he is there mentally in a minimally conscious state because he tries to move his left thumb to say bye when we ask him a few times. What the nurses feel like we are thinking too much. Well, it doesn't really matter what the nurses think. You know, there is no speech therapy anymore, no mobilization as well. We ask if he has any bed sores, and the nurses say none. Well, that's the bare minimum to keep him free of pressure sores. You know, that is something that should be a given. What worries me is if there's no speech therapy, how can they find out whether he can swallow or not? Right? No mobilization, big concern. He needs to get mobilized as quickly as possible, assuming he's hemodynamically stable, assuming he doesn't have any fractures. You know, he needs to be mobilized as quickly as possible. The problem is if he goes to LTAC, there will be no mobilization there either. Now is the time to mobilize him. Now is the time to get him off that ventilator. You know, this should all happen while he's in the right environment. Then you're saying he still has fevers on and off. We talked about that the fevers could be a result of the brain bleed. It could be a result of high blood pressure, could be a result of an aneurysm, right? It could be the result of an infection, right? Once again, ask them whether they've done a sputum sample, urine sample, and blood culture to find out where the infection is and what infection it is so they can give antibiotics. Then he was doing good on the spontaneous breathing trials for 3 hours, and then suddenly, after we agreed for trach and peg, the nurses started saying he's failing breathing tests and that's why he will need trach and peg. Well, it sounds to me like he was doing quite well. Maybe it wasn't going quick enough for them. Maybe they had to resedate him. Again, you're walking in the dark there at the moment because you don't have access to the medical records. You don't have anyone helping you to interpret the medical records, right? Or talking to them directly. You will see if I was to talk to them, I would have the right questions to ask. You would see that depending on what they say, that I will have counter questions to ask and so forth, you know. And then you're saying, not sure if this is on purpose or for insurance reasons or not. We are confused what's going on. The nurses are feeling like we're bothering them, and we ask about his progress. I asked them to check with neuro doctor on putting him on neurostimulants to get him conscious. Let me know how to proceed. We feel it's too early to give up on him. We are on Medicare insurance, so it covers 100% for 60 days of ICU. We don't want to go to LTAC if we can avoid it. We are interested in DOC programs and neuro rehab once he's in on-room oxygen. Yes, absolutely. He needs to get onto neuro rehab once he's off the ventilator, right? You shouldn't be concerned about the nurses. If you think the nurses are thinking you're bothering them, don't be concerned about that. You know, you could ask them to put him on neurostimulants. You know, the first thing that you need to ask here is if he is on any sedation, propofol, midazolam, Precedex, is he on opiates such as morphine, fentanyl? Well, that will keep him sedated and it will mask his actual neurology status. Right, so that's a big issue. It will mask what he's really capable of doing. Right, and first thing, they need to stop all sedation. You know, that will also hopefully get him closer to being extubated. So how you should proceed is getting access to the medical records first. Let me have a look at them, right? Or let me talk to them directly to see whether it is realistic to get him off that ventilator. I think that's your first step here, right? Only then can I advise you whether he should have a trach or not. I'd say no to PEG for now, no to a PEG tube until you know what's really going on. PEG tubes have their time and their place. They should only really be done once someone cannot come off the ventilator beyond the shadow of a doubt in situations like that. I hope that helps, Gita. I will move on to the next question in a second. In the meantime, if you have any questions, please type them into the chat pad or come live on the show. I'll put the link there for you to join live on the show if you like. Moving on to the next question from Jeanette, who says, hi Patrick, adding to my husband's death, I want to know if I can see the video EEG when he was on BiPAP and aspirated bile from stomach contents. I want to see if this is something that could have been prevented. My husband had a right-sided weakness from his stroke, unable to use, and the headgear from the BiPAP machine he probably could not remove. I feel this was medical negligence. Well, once again, the first thing here, Jeanette, is you need access to the medical records, right? And if he aspirated bile from stomach contents, the other question is, was he on feeds while he was on BiPAP? Because that can be a risk if people can't protect their own airway. My husband had right-sided weakness from his stroke, unable to use, and the headgear from BiPAP machine he probably could not remove. Yeah, so basically what you are suggesting is he vomited and he aspirated because he could not remove the BiPAP mask. Could that be medical negligence? Potentially. I guess the other question is here, was he on nasogastric tube feeds during all of this? You know, did they feed him during the BiPAP? Because that would have increased the risk for aspiration. Now, with a stroke as well, there is a higher risk of aspiration to begin with because a lot of stroke patients can't swallow. Right? But here's another thing. If your husband was on BiPAP in ICU, he should have a one-to-one nurse. So therefore, as soon as he aspirated, one of the nurse looking after him should have taken the BiPAP mask off and should have suctioned him straight away. Right? But in order to really find out whether it was negligence or not, we would need to look at the medical record. So please contact us at support@intensivecarehotline.com, email us to support@intensivecarehotline.com, or call us at intensivecarehotline.com on one of the numbers on the top of our website. I hope that helps. Next question is from Jeremy, who says, hi Patrick, my son is on the ventilator, but off. He will stop breathing most likely within minutes. How long can he stay on the ventilator? That is a very difficult question to answer because you're giving me very little information. How do you know he will stop breathing within minutes? Is he still sedated? Does your son have a ventilator with a breathing tube or with a tracheostomy? Right? If your son is on a breathing tube, he can stay on it for about 10 to 14 days. If he can't be extubated, he should have a tracheostomy. But in the meantime, why does he stop breathing? Does he stop breathing because he is still sedated and he still has opiates? You know, does he have sedation such as Versed, Propofol, Presidex? Is he on opiates such as morphine or fentanyl, or a combination of all of that? Is that why he stops breathing? Right? One of the main side effects of opiates in particular, is respiratory depression, i.e., patients can't breathe. When they take morphine or fentanyl, it's less likely for them to initiate spontaneous breaths. You know, is that why he will stop breathing within minutes? If your son has a tracheostomy already, you know, he can stay on it forever, really, you know, assuming he can't get rid of it, right? If that is the case, if your son needs a tracheostomy and a ventilator in the long run, you should be looking at intensive care at home at intensivecareathome.com. Because at intensive care at home, we are sending critical care nurses into the home to look after long-term ventilated adults and children with tracheostomies or otherwise medically complex patients, right? So that is what's probably going on with your son. But you should absolutely reach out to me either at intensivecarehotline.com or at intensivecareathome.com. Next question. Just give me 1 second. Okay, let's get on to the next question. Next question is from Alicia, who says, "Hi Patrick, my husband is in a medically induced coma for detox. 25 days later, he's having a tracheostomy and still ventilated and unresponsive." Right. Okay. So what you haven't shared with me, how many days has he been in a medically induced coma? And when did he have the trach? So here's the normal trajectory in a situation like that. Someone gets intubated, you know, he needed some detox, in an induced coma, probably can't come off the ventilator, then needs a tracheostomy. One of the main goals of a tracheostomy is to eliminate the need for sedation, give patients more time and help them wake up, you know, get them mobilized, get them physical therapy, and then ideally wean them off the ventilator, right? Now, if he's still unresponsive, the question is there a neurological condition? Did he have a brain injury in the last few weeks, right? Did he have a cardiac arrest leading to a brain injury? During the detox, during the potentially drug overdose, was his brain starved of oxygen? Are they potentially still using sedation at the moment, even though he has a trach, which from my experience is not necessary. Most patients in ICU should be off sedatives with a trach. You know, that is the main reason to wake them up, right? So here's another question, Alicia. Are they mobilizing him? Are they getting him out of bed to help him wake up? Are they doing physical therapy? Have you spoken to a neurologist? What's the neurologist saying? So I hope I make that clear, what needs to happen here. You know, have they done an MRI scan of the brain, a CT scan of the brain, an EEG? Why is he not waking up? Is he lying in bed all day on sedatives and opiates? No need for that. Get him to wake up, get them to stop sedation and opiates if they haven't done so already. And if he has been off sedation and opiates in the last few days or weeks and he's not waking up, you know, ask the neurologist, have they done a CT scan of the brain, MRI scan of the brain? Have they ruled out a stroke? Have they ruled out ongoing seizures? Right? Are his kidneys working? Are his liver working? Because if he's in kidney or liver failure, right? He won't get rid of or there's a delay in metabolizing and excreting sedatives and opiates, and that might delay him waking up, right? So let's move on to the next question. And if you have any questions, please type them into the chat pad or join me live on the stream here. I put the StreamYard link here. You can just click on that and you can join me here live, either on camera or off camera, but you can definitely talk to me here if you want to. Next question from John, who says, "Hi Patrik, my wife died in ICU and I was kept from seeing her based on accusations from her sister that I had a FVRO against her. I was kept from saying goodbye, and the hospital and police allowed the sister, who feared my partner's very existence, but was given control over pulling the life support of her or not. How can someone be given the opportunity to end someone's life whilst having a family violence restraining order on her?" Right. I guess the biggest question here, John, is, are you or were you the medical power of attorney or not? It doesn't sound to me like you were, because you're talking about your partner, not your wife. So I guess someone else had the decision making here and not you. I am not a lawyer, right? I am not a lawyer, but whoever has the decision making authority in those situations can make decisions, rightly or wrongly, right? Rightly or wrongly, but unfortunately, if you're not the power of attorney, you don't have any say in all of this, unfortunately. So you got to consult a lawyer here, you know, why this happened the way it happened. So I can't really answer your question. So next comment from Ariana, who says, "Can intensive care teams know if patients in coma after cardiac arrest, if the patient has brain damage just with the scan?" Yes, absolutely. They can work that out in a MRI scan of the brain or a CT scan of the brain if there has been brain damage. Right, very simple. Very simple. I hope that answers that question. Then next question is from, again, Helene makes a comment saying, "Hi Patrik, is it non-compliance when the surgeon did not give my elderly late mother any pain medication after tracheostomy procedure? This is what happened to my mom." No, it's actually not, because the whole purpose of a tracheostomy is not to need pain medication, not to need sedatives, right? That is one of the main purposes of a tracheostomy, that when someone is on a ventilator with a breathing tube, can't be extubated, need a tracheostomy. When someone has a breathing tube and a ventilator, it's very uncomfortable, very painful. So therefore they need sedatives and opiates, painkillers. So therefore, if the surgeon hasn't given your mom painkillers, that might not necessarily be a bad thing, because your mom should have less pain after tracheostomy than before the tracheostomy, right? Could there be some post-surgical pain? Yes, there could be, but it should be temporarily, very short-lived. Okay, next question is from Gabrielle, who says, "Hi Patrik, my frustration is nursing, especially the night nurses. My mom is not getting the proper care and attention in LTAC." Well, no surprises there. You know, I've been talking about LTACs for many years, that patients and families do not get advice, do not get the right nursing care and other care in LTACs. No news there. Absolutely no news there. Right? Don't go to LTAC. What's the alternative? The alternative is to stay in ICU for as long as it takes. And the alternative is to keep standing your ground. You know, making clinical arguments. This is what we can help you with. We've helped so many families to stay in ICU for as long as it takes, rather than letting them go to LTAC with our advocacy, right? We'll find reasons when we look at medical records, we'll find clinical reasons why a loved one is not a candidate for LTAC, right? Because we're the specialists in intensive care, we can help you with that. Okay, next question from Sabine. Sabine says, "Hi Patrick, my boyfriend was found unconscious in the bathroom on Tuesday and was transported to the hospital after a few hours, diagnosed with bacterial meningitis, and he had a seizure in the ambulance. He's been in an induced coma ever since. They did try to wake him up, but he's not very responsive and he's very strong and starts fighting him, being restrained to the point where they have to calm him down again. Yesterday, in a more awake state, he opened his eyes when he heard my voice and looked me in the eyes, but I'm not sure he was," she puts that in quotes there. "I once again asked him if he can wiggle his toes, and the nurse said she saw him do it. He had to have a lot of CT scans and MRIs and needed to be fully sedated. So often, he never had a chance to wake up fully. I haven't eaten in almost 3 days. I can't sleep and don't know how to cope with it. I'm in a foreign country with no family close by. He has blood clots in his brain. I hope they found them early. And a swelling in the lower part of his brain that's concerning. He might need surgery. He's a very fit 40-year-old male with a strong heart and a strong will. I know that doctors shouldn't give you false hope, but I've been thinking about all the worst case scenarios, and all I need is someone to give me a little hope. I hope young guys can give me at least words of comfort. I hope you guys can give me at least some words of comfort. I'm not a medical expert by any means, so I have no idea what his odds of survival are. I just can't imagine my life without him anymore." From Sabine. Okay, so here's the thing. If you look at the research, approximately 90% of intensive care patients survive. They survive their intensive care stay. So that means the odds are in your boyfriend's favor, right? Now, to leave intensive care alive. Now, what we don't know is, what does quality of life look like down the line? We don't know that, you know. Now, it's only been a couple of days, and 2 days in ICU is not a long time. Okay, they're still probably just scratching the surface. They've got a primary diagnosis, you know, what's the prognosis? Very early days, right? And because he's now being in and out of comas because of the MRI scan and the CT scans, you got to let things settle down a little bit. And then the next step should be, they should wake him up, right? See what he can do, see whether he can breathe, extubate him as quickly as possible. Now, I do understand he's not very responsive and he's very strong and starts fighting him, and that's why they have restrained him. Now, this is a big challenge because, you know, you need a patient to be calm and cooperative when you extubate them, and calm, cooperative, and also obeying commands, you know, and it sounds like he may not be there. But sometimes that is what it is, and sometimes that is what it takes to get a patient out of the induced coma and extubate them. It's a bit of an art rather than a science, you know. Sometimes you have to switch off sedation, see what a patient does, and then, you know, if it doesn't work, resedate him, try again. Sometimes it takes a few attempts. But if he's strong, that also means he should be able to breathe eventually by himself, you know. And if he's got a bacterial meningitis, have they done a lumbar puncture, right? A spinal tap, to see whether they need to give him, or how they can give him the right antibiotics for the bacterial meningitis, right? Given that he's had a seizure in the ambulance, he's probably also on anti-seizure medications now, such as Keppra or phenytoin, right? So, and it's good that he can get into a more awake state. That is a good sign, you know, especially when he's heard your voice. You know, he's wiggling his toes. You know, those are all good signs. You know, Now, if you're saying they've got blood clots in his brain, that is certainly dangerous because that could have triggered a stroke or more than one stroke. You know, what are they doing for that? Are they trying to thrombolize those blood clots? You know? And the swelling in the lower part of his brain, that's concerning. Well, if he's got swelling in the lower parts of the brain, you know, they might need to give him some mannitol to get the swelling down, or some 3% or hypertonic saline to get the swelling down. Right? I'm not here to necessarily give you hope because I can't predict the future. What I will say is, you know, most patients in ICU survive. That's what I will say. So the odds are in your partner's favor. You know, but they need to get rid of the sedation as quickly as possible. Problem here is with the meningitis, you know, will that trigger some seizures? It'll be a fine line here whether he can wake up or not. Be a very fine line. You know, have they started him on the right antibiotics? What sedatives is he on? Is he hemodynamically unstable? Does he need other mechanisms of life support, such as vasopressors, inotropes? Are the kidneys working? Is the liver working? What do the blood results show? What do arterial blood gases show? You know, what's his Glasgow Coma scale like? Are the pupils equal and reactive to light? Okay, now we are going to wrap this up in a minute. Now, if you have any questions, please type them into the chat pad now before I wrap this up. Right, I usually do those YouTube lives once a week, usually on a Saturday night, 6:30 p.m. Eastern Standard Time in the US, which is 3:30 p.m. on a Saturday afternoon Pacific time in the US. It's 10:30 a.m. Sydney, Melbourne time in Australia, and it's 11:30 p.m. in the UK. I usually do them once a week. Today's an exception because of New Year, but I'll be reverting back to doing them once a week on a Saturday night, 6:30 p.m. Eastern Standard Time, 3:30 p.m. Pacific time in the US on a Saturday, which is 10:30 a.m. Sydney, Melbourne time in Australia on a Sunday. Now, if you want to continue the conversation, go to intensivecarehotline.com or to intensivecarehome.com if you need home care, and contact us there on one of the numbers on the top of our website, or send us an email to support@intensivecarehotline.com. Also, we have a membership for families of critically ill patients in intensive care at intensivecaresupport.org, or if you go to intensivecarehotline.com and you click on the membership link. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. I also offer one-on-one consulting and advocacy for families in intensive care over the phone, Skype, WhatsApp, Zoom, whichever medium works best for you. And I talk to doctors and nurses directly, and I ask all the questions that you haven't even considered asking but must be asked, so that you make informed decisions, have peace of mind, control, power, and influence. I also talk to you and your families directly, of course, and I set you up with the right questions to ask. I also represent you in family meetings with intensive care teams, so that you're not there without clinical representation. You need clinical representation in those meetings. You know, the intensive care team needs to know that you have someone on your team that understands intensive care just as well as you do. Right? We also offer medical record reviews in real time. If you know, you want us to help with that, you can get a second opinion in real time very quickly. We also offer medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are simply suspecting medical negligence. And all of that you get at intensivecarehotline.com. And if you want home care, you will get that at intensivecarehome.com. Now, if you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care. Click the like button, click the notification bell, share the video with your friends and families, and comment below what you want to see next or what questions and insights you have. Thank you so much for watching. This is Patrik Hutzel from Intensive Care at Home and intensivecarehotline.com, and I will talk to you in a few days. Take care.